Good afternoon, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by the panelist who is here with us today. So today I would like to introduce our moderator and speaker for today's session. He is none other than Dr. Ash Sujit sir, who needs no introduction at our platform. He is a senior consultant in gynecology and obstetrics department at PD Hinduja Hospital, Mumbai. And the topic for today's discussion is liver disorder in pregnancy world on World Liver Day. So before moving on to today's session, let us have a brief look on what the topic says. Pregnancy is a time of great joy and anticipation for women, but it can also pose unique challenges to the health of both the mother and the developing baby. Among the various complications that can arise, liver disorders during pregnancy, including gestational liver diseases, viral hepatitis, fatty liver disease, and intrahepatic cholestasis, require special attention due to their potential impact on maternal and fetal well being. So, we'll be learning more on this occasion of World Liver Day about liver disorders in pregnancy. So, now without any further delay, I would like to welcome the moderator. I would like to hand over the session to Dr. Ash for the session to begin. Sir, over to you.
Thank you, Batul. Thank you, Team IGCP. And I like to welcome you all on behalf of IGCP. I'm Dr. Ash. I'm a senior gynecologist at PD Hinduja Hospital, Mumbai. Today, we'll be talking about liver disease in pregnancy. So, as we've all been hearing, or as doctors, we've all known or come across certain liver diseases which affect pregnancy, or you might have come across some patients who always have certain abnormal reports, and then you think that what needs to be done when it comes to liver enzymes which have been deranged. Ideally, not all things need to be checked into. Physiological changes also happen regarding the enzymes when it happens to the woman happens to be pregnant. Majorly, as gynecologists, guess we are worried about the acute fulminant hepatitis. That is what is something which is very shocking for us, or hepatitis E in pregnancy. That is shocking for us, or it might be something which is just associated with pregnancy, like a health syndrome. Then that becomes a difficult task to manage. So we'll be touching on a few topics today with Dr. Manjulata and Dr. Manish. Let me introduce Dr. Manjulata and Dr. Manish. Can you all send me the slide, please? Yes. So today we have among us Dr. Manish Bhatnagar. He is the founder chairman of Icon Hospital in Ahmedabad. He is FACG, MASGE, and AGAF, and he's the winner of Times of India Health Icon Award in gastroenterology and hepatology in 2017 and 2018. He is the first in Western India to do a fecal microbiodata transplantation. Okay, honestly, I don't know this. I'll be hearing more about this from Dr. Manish. He's a visiting faculty at IMA on medical economics, and he has around 12 international and 30 national publications in various journals all over the world. And he has contributions to the API textbook of medicine, the ISG handbook, and other important textbooks, which are basically dealing with chapters of GRD, probiotics, cirrhosis, and non-alcoholic fatty liver disease. And he's a life member at various organizations. I'd like to welcome Dr. Manish.
Thank you so much.
Also among us, we have Dr. Madhulata Alexander. She is a professor of Osmania Medical College at Hyderabad and a gynecologist, a fellow gynecologist like us. So, hello, madam. She is
Good
awarded by the
afternoon.
commendation by the district collector at Mahabubnagar and Nizamabad for meritorious service, and has a Best Paper Award in OBGYN Conference too, and has a teaching experience of more than 27 years. Madam has been a part of various conferences as a faculty and as a speaker, and has special interest in adolescent and geriatric gynecology, infertility, family planning, and research activities. With that, I would like to welcome you, Madam, too.
Thank you, Doctor.
So let's begin with our discussion. So
चल रहा है सेशन.
As I was going through some data, I have seen that there are a lot of physiological changes in pregnancy that happens when it comes to LFT also. Like I was just giving a brief highlight, not everything when it comes to an elevated liver enzyme or anything which has to be managed always. So, Dr. Bhatnagar and Dr. Madhulata, can you all just share some insight on that?
Yeah. Okay.
Uh,
I will
Ma'am.
begin with Dr. Manish.
Yeah.
Yeah,
Thank you so much. Thanks, Dr. Ash, for those kind words of introduction. And like you rightly said, that any altered LFT in pregnancy is not necessarily a cause for concern or something which merits aggressive investigation or even treatment for that matter. Now, one needs to understand that pregnancy and the liver, there is there can be multiple things which can impact. The first thing is the physiological changes which you mentioned, and in the physiological changes, one can see in terms of even a clinical examination things like palmar erythema and telangiectasia and all, which makes you think of chronic liver disease, but is actually a very very common accompaniment which is very visible in patients who are fair complexioned. So this is obviously something one needs to keep in mind. It's a physiological change because of the hyperdynamic circulation and doesn't need to be chased. The other thing which one needs to keep in mind is that there's an increase in the serum alkaline phosphatase with the uh, liver responding as if it is in a state of cholestasis during pregnancy. Plus, the liver also has an increase in the clotting factors because pregnancy itself is a hypercoagulable state. So, these things, if they increase, there should be no cause for concern. Other things which usually do not change are SGOT, SGPT, and gamma GT to any significant levels. Now, when I say significant, depending on what your lab normals are, it should not exceed 2 times normal. If it is anything above 2 times normal, then probably if the patient is symptomatic, one would need to launch an investigative hunt as to what is the reason for that. But by and large, if you have, say, 1.5, just close to 2 times normal, you should just let it be if the patient is asymptomatic.
correct. Dr. Madhulata, you want to put in
yeah,
some insight on
yeah.
this
I
too?
would just like to add something.
Yeah,
See, because of in pregnancy, there is a physiological hemodilution, which actually helps our
correct.
baby to
Yeah,
get more blood.
yeah,
There is an increase in plasma, there's a decrease in the blood. So therefore, the serum albumin becomes low. So this should not be a cause of concern. And also, because of the growing gravid uterus, the liver will not be palpable. So this is a normal part of pregnancy. Therefore, we should interpret these signs as normal. And as Dr. Bhatnagar said, in cirrhosis, we get this spider angiomas and all that, which can be interpreted as normal in pregnancy, and usually it regresses after pregnancy.
Absolutely.
true. So, as I was doing my study, there are a few things. I guess there are doctors out there among us who are students also and resident doctors. So, I'll just give a brief highlight of what I came across. So, the things that usually we will be checking about in pregnancy. So, of that, like how Dr. Manjulata said, hemoglobin tends to decrease because of hemodilution. So, that has to be evaluated in detail. You just don't rush into thinking that there is some anemia which happens in the globulin level and albumin level will also show a decrease because of hemodilution. The WBC can increase because this is something which we always see, and that is what I have seen a lot of doctors get worried about. The WBC range can be a little on the higher side. That also needs not to be worried about. Again, if you have a significant complaint or that thing, and then the WBC is high, then you don't ignore that aspect. But yes, WBC can increase. Apart from that, bilirubin can remain unchanged or it can actually slightly decrease. Your aminotransferases like the SGOT and SGPT that can be unchanged. The prothrombin can be unchanged. But clotting factors, yes, a little derangement is expected because, as Dr. Bhattagar said, that this becomes a hypercoagulable state. Therefore, you have a fibrinogen level which can increase up to 50%. The main thing that we look into is the something which gives alarming jitteriness to a doctor is the alkaline phosphatase rising, but then increase up to 2 to 4 fold is usually seen to be normal whenever a
Normal.
lady is pregnant. So I guess this is basically what we think about whenever we are thinking about the physiological changes which happen in pregnancy. Now, coming to my second thing that we usually discuss about or we come across is what are the case scenarios you might have come across for liver disease in pregnancy. Let's begin with Dr. Manjulata this time. So the
Yeah,
scenarios, various scenarios, if you have come across, and then we'll go into detail regarding each as we go ahead in the topic.
yeah. See, I work in a government hospital, so we see a lot of variety of cases. The very common factor what we see, and we give the references to the gastroenterologist is HELP. We see a lot of patients with HELP, PIH and HELP syndrome. This intrahepatic polycystic of pregnancy and AFLP, we rarely come across. And if we come across, it is definitely, as you know, it's an emergency. It has to be dealt with. But nowadays, what I can say is we are doing very well in these gastro cases. Most of the patients of HELP come through with the and also we all have, the government has given us a lot of benefits. We are tied up with bigger hospitals, so we can get immediate referrals. And the most common, as I said, what we come across is HELP and preeclampsia, which affects the baby, which affects the patient. Well, hyperemesis gravidarum also, which can affect the liver, which is nowadays we don't allow it to go to so high because I think patients come earlier to us and
Yeah.
there's good medication and everyone knows the thing of hydration. So that's not such a, those olden days we used to see bad cases, but nowadays we hardly see
Yeah.
these cases. So I think definitely our antenatal care and awareness, not only in the private sector, in the public sector also has improved. And the government has contributed a lot to it.
Yeah, yeah, yeah. Dr. Mani, what about you? What is the maximum reference cases that you get?
See, I would agree with what ma'am said. We get a lot of references for help and not so many for acute fatty liver of pregnancy. The hyperemesis gravidarum cases we continue to see quite frequently, along with cases of recurrent intrahepatic cholestasis. Most of these recurrent intrahepatic cholestasis are those patients who had it in their previous pregnancies or when they have twins or maybe there's a family history. AFLP, fortunately, where there is a significant mortality and morbidity, is not that common, but I would not say it's unusual for us to see about 6 to 8 references in a year, and that too in a fairly major city. So that's not a very large number, but I think most of the times AFLP, we are criminally underdiagnosing it, and many of
Yes.
these patients do not have severe AFLP. But when you take a retrospective history later for something, when they present as chronic liver disease or they come with some liver dysfunction postpartum, then one feels that it was probably AFLP which they were dealing with, which somehow nature has assisted them and they have come through. Like ma'am said, I think the public sector here also has stepped up to the plate in a big way. Maternal mortality due to GI cases has definitely gone down. I think even the fetal distress and the fetal wastage because of this has decreased. And with more and more gastroenterologists, practicing gastroenterologists with a proper training are increasing, at least in the metropolitan areas. This is becoming far better managed, one would say, though it is not exactly, the incidence doesn't seem to be decreasing. I think we still see a large number of cases, but they are probably being managed earlier and better.
Yeah.
One
Yeah,
thing
I would
which
just
I
like to
would
add to one thing. Yeah.
yeah, I'm sorry, ma'am.
Yes,
One
doctor.
thing
Please
which
go
I
ahead,
just
doctor. No,
wanted
please
to
go
add
ahead,
is
doctor.
one particular subset of patients which I get called in very frequently is the last trimester patient with hepatitis E. And
Or just
hepatitis,
coming to yeah.
yeah, hepatitis E, actually, we are in Ahmedabad, which was the epicenter of one of the largest epidemics of hepatitis E as far back as 1983. And we have certain areas where it is almost holo endemic right through the year. It gets worse during the monsoons, mainly because there is a mixing of the sewage and drinking water due to prehistoric water supply from the British times, which has not been replaced or refurbished. So we do see a lot of these cases, and unfortunately, there the mortality and morbidity continues to be sickeningly high, because many of these patients do not get referred to us till they have already stepped into the realm of fulminant hepatic failure. And now, with transplants available in Ahmedabad, with 6, 7 centers doing transplants, we've been able to salvage a few patients. But I think those are solitary successes most of the times. Many patients slip through the net and they don't do too well. So I think this is one area where all of us have to refocus our attention and maybe look at even sensitizing the gynecologist regarding the condition of hepatitis E in the last trimester, which should be, one needs to be far more proactive than one is at this moment in time.
Yes.
Uh,
Yes, Dr. Manish, very true. Actually, I work in the hospital where I work, we have about 25,000 deliveries a year. In spite of it, about 2 weeks back, one AFLP just slipped through our fingers. It was total mismanagement. It was referred by a junior resident to the higher center, but total, when we went back and looked at all the records, it has been totally mismanaged, which could have been corrected in a center like ours. So still, we have a long way to go, but we have come a long way too.
Absolutely. I would
Totally, it
agree
was
with
totally mismanaged and slipped. It just slipped through our fingers.
so hepatitis E is something which we see very commonly in monsoons, even in Bombay. And I remember when I was in Ahmedabad, there are a lot of poles, if I'm correct.
you. Yes,
So all the
absolutely.
poles have underground sewage system which is there, and they have. I don't know, madam, if you've ever visited Ahmedabad, they have nice tanks which are there, but then everywhere they have a marker
Yeah,
that this is a
the
sewage
Kuwait.
connection which comes in. Yeah, the sewage connection or the water connection which happens in. So that is something which gets waterlogged or something can happen because of the rainy season. So this is something which I was discussing with one of the doctors out there also. So this is one of the major, and they have a lot of street food. Ahmedabad is known for its street food. So yes, so that mixing with the street
Yes,
food, then
yes.
it becomes calamitic. So again, usually what I say my patient like yes, help and everything I can diagnose and those can be worked on. But hepatitis is something which is always one can be very cautious about it. So I guess
That is
among
there.
all the things that we'll be discussing today or we'll be touching upon, I think one of the most preventable liver disease that we can do or work on is hepatitis E, and it's one of the most dangerous ones. If I'm not mistaken, that's like the one of the most dangerous one, which is actually
Yes.
preventable. The good thing about the other diseases is that yes, the awareness has increased. We are more. There's one thing which we say that the mind only knows what we have again seen or what we have come across. So we have seen it with our eyes, and we've all, I guess, come across one or the other cases. So everyone knows about that. And when you see anything, we think about yes, this can be that, this can be that. If a patient comes with itching, then we think about the intrahepatic cholestasis, or if you have something like a jaundice which happens, and then you think about it, which is very rare getting a jaundice. But then yes, health that we think about. Yes, you have a clinical scenario where you have a high blood pressure. So I guess all these things at least we have been trained about and we can work on it in a multidisciplinary approach. But then hepatitis B is somewhere I feel that we can be very cautious
Yes.
about. And that is something which needs a little more awareness from the patient's point of view also. So beginning
Yes.
with, we'll maybe just touch each of them a little bit here and there. So let's begin with the smaller thing, which is very rarely seen nowadays, but then the hyperemesis gravidarum, because we are managing it so easily, and the patients have become so aware that any vomiting the patient, anyways, we try to manage it with once like from our end, what we do is when the patient becomes pregnant, right from like starting folic acid, I give them medication. This is your antacid. This is something for your vomiting. Take it and keep it with you handy. Don't let the things increase. And if anything happens, I even give them something which is like a mouth dissolving thing. If you can't swallow water, take a mouth dissolving and you'll be better. And if nothing happens, then you can reach us anytime. So at least we have been like we are so far that yes, this, nahi to this, then you come to this. I guess that is what we are getting it in the private practice and even government. I have seen that this is something which I've picked up from a government scenario because the patients can't reach out every time, so they have been given a bulk of medications. These are the things that you'll have. The Anganwadi workers are working with it, and things are much better. So, madam, would you like to share some of your experiences with hyperemesis?
See, hyperemesis, as I told you, we hardly see nowadays. But as you say, nowadays the government, the ASHA workers, is the patients have very easy access to the healthcare system. So not only are these ASHAs and these ANMs, they are trained, they also educate them to even get hydrated and all. So very rarely, I'm telling you, it's so rare that I told you, as I told you, 25,000 deliveries we have per month, per year. We hardly see hyperemesis nowadays. Maybe at the most one or two, and then that is just for a short time. Even the private sector, we're hardly safe. Just for a few days, we admit
Yes.
them, and we it never goes to a level of giving thiamine injections, steroids, and all. No, but we are careful because anytime there is a patient with with either twins or molar pregnancy, we look after all these other things. So as you said, it is managed in a much better and scientific way nowadays, even in the public sector.
Like, honestly, I just remember over the last, I guess I'm the youngest out here among the three of us. So in my limited
Yeah,
last
you
10
are.
years of work that I've seen, I've just seen one patient who was given steroid because she had hyperemesis throughout the entire 9 months. And she got so fed up that, "Doc, give me something
Doctor, not able to
because
hear
I'm
you.
not tired." There's some network issue. Is it from my end or Dr. Manish? You will be better to.
I can hear you, Dr. Ash. I can hear you loud and
Okay.
clear.
I think Dr. Madhulata is having some network issue from her end.
Yeah, it's
So,
raining quite heavily in Hyderabad, I'm told.
and here also.
Yeah,
So yeah, so I guess only one patient had a steroid thing which we had given, but apart from that, yes, the nowadays like over the last 3 years, I have had three patients. I remember vividly with their names. They had come in again and again with hyperemesis throughout the pregnancy. Usually, we expect it to settle in the first 10 weeks at least of the pregnancy, but then if anything like that happens, the reference or the patient is pushed to the gastroentero. So I
yeah.
would like to, Dr. Bhatnagar, if you can just put in what we should be thinking about and what are the things that you expect us to do when it has to be managed when the patient has intractable hyperemesis.
I think intractable hyperemesis gravidarum, you would definitely need to refer them to a gastroenterologist to rule out some other coexistent cause for the reason for this. You see, many a times we tend to forget that a pregnant patient could be having some pre-existing condition which gets worse due to the pregnancy itself. Just to give you something which is completely off track, we are talking about the liver. Like say something like IBD, a patient has ulcerative colitis, gets pregnant, continues to be on 5 ASAs throughout the 6 7 months of pregnancy. But in the last trimester, it is known that due to the changes in the hormonal levels and all, there is a definite predisposition towards a flaring up of that disease. Similarly, even with hyperemesis gravidarum, you have patients who probably were H. pylori positive to start with, who might have had a past history of gastric ulcer or a duodenal ulcer, could be having chronic gastritis, which gets worse due to the stress of pregnancy and also the attendant changes which happen in the body. So, if you have intractable vomiting, I think, and you've tried all the things, then the best thing is to subject them to an upper GI to rule out anything which is of a treatable type. Most of the times, we would avoid investigating these patients beyond the usual blood tests, where we are basically looking at the electrolytes and other things just to get a sense of how badly the patient is decompensated. But like ma'am said, and like you said, the references for hyperemesis gravidarum are decreasing. Patients are quite well aware. They now stay well hydrated, and there's so much information available on the net that people are able to pretty much take care of these things, and most of it is self-limiting the majority of the times. I would endorse both of you in that statement that we also hardly see about 2 3 patients in a year, and that's about it. And I haven't used steroids in those patients for as long as I can remember. It's been a while.
Guess we are doing better when it comes to the hyperemesis gravidarum, at least everywhere, because we have covered West and I've seen Dr. Madhu from Hyderabad, so even the South is covered, and you have covered the North, if I may say so. I guess we are doing better when it comes to hyperemesis. So we'll,
Yes, sir.
I guess, end with the topic because I think hyperemesis is something which everyone can manage it quite well. We'll move over to something which is very common, like Dr. Madhu also was saying, and something which we see very commonly in our practice is pregnancy-induced hypertension, which gets complicated. So, not much, but only around 5% patients can get complicated and can land up with something which is known as health syndrome, which is again a nightmare for us, the gynacs, because this requires immediate action, not just for the mother, but we have to think from the baby's perspective. Yes, it's predictive. The clinical scenarios are something which will give us a better idea because we know what specific questions we need to ask for when you are moving towards preeclampsia and help. But then again, the management becomes a multidisciplinary thing because we are not just handling the mother and the baby and the blood pressure, but again, this is the time when the liver enzymes get complicated. This is the time when the patient will have pain in abdomen and the clotting factors keep on deteriorating. So this is when we ask for, okay, a GI should be coming in and yes, please have a look. So this is something which we see commonly. So Dr. Manish, would you like to say something like what's the approach when you get such a patient? What's the thing that you have come across something in your clinical practice which is very startling or something which happened? And if you can share one snippet from there.
I'm sorry, I lost you in between. Is the question directed to me or to ma'am?
Yes. For you, Dr. Manish, then I'll come to
Oh,
Dr. Man.
okay, fine. So yeah, that I think is one of the most interesting and challenging things to treat when we talk about the overlap between gastroenterology and gynecology. I think HELP syndrome. I had a patient who was referred to me by my gynec colleague. I saw the patient in the middle of the night. She was in shock. She was hypotensed at that time, fairly bad breathing, and she had tenderness and guarding and rigidity all over the stomach. So, with a history of uh, not exactly full blown eclampsia, but she was being treated as a case of impending eclampsia by my gynec colleague. I put a tentative diagnosis of hemoperitoneum and maybe even a hepatic infarct. Unfortunately, when the imaging was done, this turned out to be the case. She had a large hepatic infarct, and there was a fair amount of hemoperitoneum which was there, which was the reason for her shock. Like you said, most of these patients will have altered clotting factors and almost a DIC like picture, which this unfortunate patient was in. So, in consultation with the hematologist, the intensivist, and the gynecologist, the decision was taken to go for an emergency evacuation followed by a laparotomy at the same setting. The patient underwent that procedure. There was a lot of morbidity involved. The patient was on a ventilator for nearly 2 3 weeks, and the only good news I can give you is that the patient made it, but it was hell on two wheels to manage. And one needs to be aware of the fact that apart from the classical things like hemolysis and elevated liver enzymes and low platelets and all, we also need to keep in mind that this could be precipitated as a surgical emergency, because here was a case who had hemoperitoneum as a presentation, and everything, as far as my gynec colleague told him, and I have no reason to doubt what he said, everything happened over a period of 2 3 hours, and the patient deteriorated very very rapidly. And like I said, the only good thing I can say about this whole thing was that the patient survived, though it took a very heavy toll on them emotionally and physically and financially, but at least the patient lived to fight another day. So that is one thing which I think most of our gynec colleagues sometimes can tend to overlook as a likely possibility, because this patient had been complaining of right sided pain, which was obviously evaluated, but at that time there was no tenderness which was significant, and later she developed frank guarding and rigidity, where the doubt was erased from the mind of the registrar who was seeing the patient. And that is when I got called in. Unfortunately, when I saw the patient had a board like abdomen. So there was nothing much to do except to go for imaging and then immediate intervention.
So
Yeah.
the common thing
Mm.
that we usually see when it comes to liver rupture, which is there. So this is for the doctors out there, is that you can see something when you do a sonography. Is you can notice an intraparenchymal hemorrhage, which can also be accompanied with a subcapsular hematoma, and specifically this affects the right lobe of the liver and the part one of the lobe of the liver, and this can lead to rupture. So these are important things which is out for the doctors out there. And yes, since you just mentioned, I'm going off topic, but then we had one case where we were just thinking that the pain in abdomen is because of preterm labor or something like that, and you keep on giving some relaxant, uterus relaxant, and try to manage it. That patient, like not just for like it's not just for academic purpose, that patient had a renal pelvic cholesterol rupture, which are like hardly less than 40 cases which are documented all over the world. And this is what happens. You just learn from whatever you have seen, and then we have to call in a euro. So similarly, we have seen hepatic in like ruptures which are happening because it was that was in my government days when I had worked there. But we have I've also come across, and it's massive because the thing is we have to understand that this is something a rupture which is happening to a patient who already has clotting factors which are deranged. So
Exactly.
then the
Yeah.
bleeding is like a tap.
Massive.
It
Yeah.
just hurts. And that is why it requires a surgeon to be around, because liver is anyways a very vascular organ. You can't take just any bites on the liver because it will start shearing off, because the liver is already insulted because of the high blood pressure. And you have a clotting factor which is deranged, and you have a bleeding, the gush of blood which is happening there. So yes, it's a nightmare. But then yes, we all might, I hope nobody comes across, but then we might be experiencing something like that. Dr. Madhulata, you want to share some experience when
Yeah,
it comes to?
yeah. Actually, we see a lot of this preeclampsia and eclampsia cases. Few of them go on to help. Now, what I'd like to say is one interesting case. One patient had come with had come with right upper quadrant pain, and all her parameters were normal. So what I'd like to tell all the young people who are there is you must repeat. If there's a chance, if there is a right upper quadrant pain, repeat the investigations after a few hours. Okay, and then all the reports came deranged, and finally this patient had a DIC, but she did not need laparotomy. It was corrected early with all the FFPs, everything was available, and it was just going to rupture. But this patient had a very good post. She we immediately evacuated the uterus, and she did well. So what I like to say, even with the right upper quadrant pain is very sinister in obstetrics. We must re-evaluate the patient and not allow her to go away.
That's important because, again, I'll go back again to my postgrad days where I had a friend who was doing a study. So we usually have a high blood pressure criteria where it goes above 160, maybe 140, 160 systolic and diastolic above 100. But she had done a nice study. What if the patient already has something like a low BP throughout her life? So if her BP is always around 100 by 70, for her, even that 140 will lead to something like a very bad preeclampsia. So then, even 140, sometimes or most of the times, we as gynecologists tend to relax and think that yes, this can be just at the settling of preeclampsia. But then, for that single patient, when her BP has throughout her life remained something like lower, that 140 becomes significantly high. That's one thing, because yes, we tend to overlook sometimes and we just think that happened. And second, we in the area where we practice, the hospital where I practice, we have a norm that try to repeat things after 6 hours. If you think that things are normal, at least at 6 hours criteria, yes, you can repeat it earlier. But then clinical symptoms, help is something which is very classic. You have all the preliminary premonitory symptoms which can happen, and everyone knows about it, the blurring, the pain and everything which happens along with the high blood pressure which happens, vomiting and everything. But then it just takes 1 hour time when you go and palpate the abdomen. And most of the time, what happens as obstetricians, we just palpate for the uterus to check for whether the uterus is contracted or not. And if that is fine, we just leave it there. But we never go up, a little up, and check for the right upper quadrant and see ever wherever there is a hypochondriac pain which happens in, or we don't even tend to go down and check for the appendix. This is something which I tell my juniors, my resident doctors, like, there's an abdomen in front of you. It's not just the uterus that you're trying to manage. There's a lady, there's a patient. You have to see the patient as a whole, a clinical scenario which is there. It's not just the uterus and everything. FHS Sundia, that's not the thing. Try to look after everything. It's not just one odd thing that you tend to, yes, happen specifically in cases of PIH, because that is something where you have to check for the liver thing. You check for the entire abdomen because the hemoperitoneum might be there and you might not even realize till the time the patient starts complaining with the bleeding, or if you have a severe tenderness. So check for the flanks if it is something which is there. Yes, you won't find something which is massive because the uterus is already sitting there, but that little thing which you can be a little more aware, I guess that will help all the doctors out there to get a little better during that scenario. So I guess help, yes, we have, I think we've covered or touched upon the important points that I usually thought that we should be sharing from experience. Now we'll move over to intrahepatic cholestasis of pregnancy. Dr. Madhu.
Yeah, intrahepatic cholestasis we do see because it's supposed to the typical case scenario we know the patient has a thing. But nowadays, what we do is we do the LFT, but always we cannot be doing the bile salts, isn't it?
It's
Sometimes because
expensive
it's a little
and it's
expensive
not
and
available easy.
it's not available in all places. So
Correct.
if the patient is not responding to normal things, then go ahead and do the bile salts. And we know if more than 40, we have to be careful, and more than 100, definitely we have to terminate the pregnancy.
True, true.
See, if the patient is term, it's easy, but the only thing problem comes if it's preterm, how will you manage? That's why we need multidisciplinary. We keep asking our gastroenterologists what to do, how long we can continue. And now with this ursodeoxycholic acid,
Yeah.
patients are doing much better, isn't it?
Yes.
We are giving a lot of it. They are doing better, but
Yes, we also do.
only thing is the termination of pregnancy we have to be, at least the
Correct.
patient should be
So,
term, but the baby also we have to
like,
think about.
honestly, coming from a Bombay metro, even we find it difficult to ask for the bile acid testing because even that goes from one lab, only one lab specifically,
Yes.
which can give me a report which is there within 3 to 4 days. Yes, that's the number of days also where I require. But the good thing about ICP is the intrahepatic cholestasis of pregnancy is the clinical scenario. The patient will come with complaint of itching. And when you see that and you do your liver enzymes, and most of them are usually normal, except the bile acid that rises, but that's not seen. So if you have an itching complaint, and then I usually first give them something which is very basic, like an anti-allergen. If that doesn't settle, and by the time we ask for a bile acid and that is raised, then USDA is something patent. I guess everyone I have has heard of it, and everyone has been using it. And luckily for me, we have a good team approach. I have whosoever we want, we get it. So our GI person is always there, like, okay, this is the thing, this is the thing. So I'm lucky to be like I'm fortunate to be having a team for us. But then, Dr. Manish, for you, how does it happen? Like, what do you do about it?
Yeah, I think you're right. I also have something similar to what you have. You are working with most of my colleagues only at Hinduja, I guess. So,
Yes.
yeah. We are also fortunate that we are almost a semi-corporate sort of a setup. So we do have all specialities. But I would just like to add one thing to this whole discussion on intrahepatic cholestasis. I think
Yes.
earlier we used to call it benign recurrent intrahepatic cholestasis, and thankfully that nomenclature has dropped benign because we've
Yeah.
realized it's not so benign a condition. It can lead to significant morbidity and fetal wastage and attendant
True.
problems related to the mother and the child. The other thing is that itching is such a non-specific complaint that it can be a red herring at times. Being gynecs, I have found a lot of my gynec colleagues over-diagnosing the recurrent
I,
intrahepatic cholestasis also. So please keep in mind that these patients need a good sonography to start with. I think if you have intrahepatic biliary radicals which are dilated, forget about everything else and start looking for a CBD stone, because that is probably the reason for their itching. The pregnancy again is a very prolithogenic sort of a state, and the chances of gallstones and CBD stones happening go up by nearly 40 times in pregnancy. Many of these gallstones even resolve post pregnancy. But the problem with small gallstones is they can tend to migrate out of the gallbladder, get into the CBD, and then they can lead to obstructive jaundice, which will manifest itself with itching. So many of these patients, when they come to us from gynecologists, they are stamped as cases of intrahepatic cholestasis. There is an element of cholestasis, but you have to also rule out an obstructive pathology. That is one. The second thing I would like to stress here is that when you talk about coexistent hepatitis, like say hepatitis A or E for that matter, both of these viral hepatitises can also give rise to a cholestatic picture, and the patient can have significant pruritus even with them. This can happen in non-pregnant patients, and it definitely does happen with pregnant patients too. So these are two things which I thought should be caveats which should be kept in mind. And apart from that, I think, like Madam said, UDCA is the go-to drug. I agree with what Dr. Ash also said, that you first give them an anti-allergen because it could be a skin condition also at play, along with the fact that there might be some element of cholestasis. I have even used cholestyramine in patients who are very resistant to this thing. And I'm a big fan of using lactocalamine lotion for these patients.
I was
One
just
thing
coming to that. Yeah.
Yeah, and one thing which I always tell these patients is when they take their bath, they should not rub their skin. They should pat themselves dry, because that is something which makes their pruritus much worse. So that is something which I think many of us in busy practice tend to forget. So we've just created a sort of a flyer which we give it to them, and we try to highlight then that for them, and I think that works quite well. Most of the times, I would say this is a disease which we have pretty much well under control at this point in time.
Yes, and also
So
this
what?
disease,
Yeah.
it keeps recurring. It keeps recurring.
Record.
So the
Yes.
next pregnancy we can manage. I would send my patient to a better institute where she can be managed a
Yes.
little earlier. It manifests,
Absolutely, madam. That
isn't
is
it?
why the earlier thing was BRICS. It was called as BRICS because it was always benign recurrent. That is what was said.
Yes.
But I think the benign part has been thankfully been dropped from the nomenclature, at least from the hepatology part of it. I'm not sure if the gynecs
No,
still
it's
use that.
dropped from our end. It's
Yeah,
dropped from our end.
so I think that is we are in sync there. And like you rightly said, runs in families, runs in that next pregnancy,
Research.
successive pregnancies, found to be more with a female fetus and twins for some reason. Nobody really knows why that's so, but yeah, our textbooks do mention that as one of the risk
So
factors.
yeah. So usually the twins and the female fetus is related to the sex hormone which is there. So basically there are certain scenarios where you can actually think about that yes, this can be a female gender child. So this is one of the scenarios because the progesterone itself and the female sex hormone that affects the flow of the bile. That is why, like Dr. Bhattagar said, that we see a lot of gallstones which are commonly seen during pregnancy and rightly pointed around 40% risk which goes up in pregnancy because of gallstone which can happen. Surprisingly, one thing which is again when I was doing a research because I just did a study on non-obstetric surgeries that we do in obstetrics. So gallstones and the gallbladder related surgeries are something which goes high, but then even when you check it on the larger scale, it's hardly like zero point 0.3 to 0.5% chances that it requires a surgery. Most of the time, it can be managed. That's one thing which I just wanted to highlight. Second thing is the most common cause of itching in pregnancy is something because of drying of skin. That is something most of the time. This is for the junior doctors or the doctors out there is drying of skin. So one thing which has worked very well for us, shea butter and cocoa butter cream. Nowadays it's a fad that applies shea butter and lactocalamine is something which most the area where I practice. I guess Dr. Bhatnagar has figured out where I'm working and the clientele or the patient that we have and the calamine lotion is something which will give to staining. It's something which is a little not very sophisticated.
Not
So the
sophisticated.
shea butter and shea butter and the cocoa butter cream works fantastic. Like the drying out skin goes away, and that is something which even in a pruritus we have tried it out and it works quite well. Calamine, they all do the same thing. It's a soothing
Yeah,
thing, emollient thing, which just
it's
makes
an
the
emollient. Yeah.
skin better. The second thing, what Dr. Bhatnagar said, and I guess this is all for the doctors out there, that make sure that there's no rubbing of skin. The patting actually helps because rubbing will cause more disturbance and you'll keep on itching that area more. So again, that is something which we help. Yes, UDCA we have used it a lot. Cholestyramine is something which we are always very hesitant to start because yes, the UDCA the benefit is proven. The cholestyramine is something like okay, we still put we'll just add on to a dose of UDCA, multiply, make it 300 instead of 100. That is where we run around. But then cholestyramine again, it depends on case-wise scenario. And again, when the gastroenterologist says that yes, you have to move on to it, that's the time when we think about it. So I guess ICP will put a stop to this and move over to the next topic then. So next
Yes.
one would be we have covered almost all the important ones. Now we go on to the most dangerous one, the acute fatty liver of pregnancy. I guess that's the most virulent thing that we even read across in textbooks. Personally, I have just come across one, and we had to deliver her early, preterm, because this is something which is it just keeps on hovering around you. And whenever one patient is there in the hospital for us, it's like everyone in the hospital knows that yes, the gynacs as gynacs we have a tendency that I guess the entire hospital will know that we have one complicated patient in the ward. And by the time we had that patient and we finished everything, not just the pediatrician and not just the gynec and the intensivist and the anesthetist, I guess everyone, even the orthopod knew about that. We had a case which was very dangerous, which was something which was related to the liver. So that is how dangerous things are for us sometimes. So, madam, would like to say something about your certain experience in the
Experience.
acute cardiac.
Yeah, actually, in the previous hospital I worked in, we had it's a referent hospital. We had a few cases of it. Most of them, the main thing is termination. Once you terminate the pregnancy, the patient improves. So, in certain conditions, a few of them improve. But some of them, when they bring them too late, and it involves so many people, we were not able to save some patients. And the place where I work, there is liver transplantation is not so common, not so available as you both are working. So generally, when you terminate patients, uh, who gets the turn for the better. And we have seen, but I told you, even last week we lost a case of most probably to AFLP.
It's again something retrospective that we think about, and
Think
then
of,
maybe
yes,
at certain areas where you do a post-mortem and then you find it out or get a proper history after that. I guess that is when you come to know that yes, there was an there might have been there
might have
might
been.
have been a case of AFLP that might happen. And I had one patient where we found out only when the post-mortem was done, because it was a PHC, the CHC PHC, that level where we were working. There it's very common to send bodies for postmortem, because most matmod are like almost all matmod are reported, and this is one of the case where you see very commonly. And that is the time when we did the sectioning of the liver, and that was sent for testing, and they found fatty infiltration in the liver. That's the thing which might have been that this is a case of acute fatty liver of pregnancy, because again in this the liver enzyme might not be absolutely deranged, or it just goes on and shoots up, and then suddenly by the time you come to realize that this is something which you have to manage, it becomes too difficult. Dr. Manish, what about you and AFLP?
I would absolutely echo what Madam is saying. One thing is, I have a lot of respect for AFLP because this is an insidious sort of a disease which tends to creep up on you, and it's almost like you're blindsided when it hits you. I used to lose my shirt with my gynecologist colleagues when I was younger and immature. Today, I have a lot of sympathy for them because this is a disease which is a master mimic in so many ways. These patients actually come with weakness, lethargy, signs of vernix encephalopathy. They have polydipsia, polyuria. They might be vomiting. They might have signs of eclampsia. Many of them may have nothing but mild jaundice. And it is so difficult to start thinking of AFLP straight away. Of course, we have these very elegant criteria which are given in our textbooks, but they really do not translate very well into clinical practice, in the sense that I think for AFLP, the only thing which I would suggest to the postgrads who are logged in and to the other practicing doctors is to keep a high index of suspicion. I think that's the
Suspicion.
only thing you can do. And like ma'am said, probably the only cure is early delivery. Everything else you do is all supportive. And we all know what that support is, like giving vitamin K and intravenous fluids and supportive treatment and all. But that's really a house which is less than halfway through. Most of the times we are doing too little too late, and most of the times we are in the catch up mode. And actually, AFLP was very elegantly called in earlier times as acute yellow atrophy of the liver. And
Liver.
that, I think, summarizes what AFLP actually means. Because as we see, more than 50% of the patients with AFLP have had a history in the past or are actually suffering from eclampsia by the time they are diagnosed. The actual figures are about one AFLP case for every 16,000 deliveries. So it is not something very common. But for a country as populous as ours, that also translates into hundreds and thousands of cases. And like ma'am said, many of these people will slip through the gaps in spite of the best setups, in spite of the best efforts, because usually this is something which is a retrospective diagnosis rather than a concurrent one, which is why all of us need to have a slightly higher index of suspicion. The unfortunate thing about AFLP is that you can actually stamp it as a diagnosis only with a liver biopsy, which is something which most people will want to avoid in a pregnant female. But in case you are thinking on those lines, and if you have the setup for a transplant, it is best to be proactive and preempt things. Deliver the baby. If the lady stabilizes, great. Otherwise, they have to be put on a transplant list as soon as possible.
True. So going back to the case which I had in, because we were just discussing the clinical scenario, that patient came with delirium and she was just blabbering. Uh, just a second. She was delirium, she was blabbering, and since we were in a rural setup, the state which she was brought in, because she had weakness, she was carried. And the thing was, इसको भूत चढ़ गया है. That is how the patient presented
Oh,
because I
so sad.
remembered. And nobody was ready to listen to the doctors also because that was the criteria, like the society or the area which we were managing it. And just to advise that yes, she'll require immediate delivery because she's pregnant, or we need to just correct her parameters because liver enzyme, like just to take the blood sample to check for aminotransferase, that itself was difficult, and they took the patient back home because the thought was that this lady had something which was not medical but supernatural,
Super.
paranormal. So they had to take her back. And when we had the lady later on, she was dead. And that is the time when we did the biopsy for her. And like Dr. Bhattacharya pointed out, yes, the basic thing how you find out is biopsy. We took the biopsy from the entire liver and the fatty degeneration that you notice because it's atrophy and fatty. That's something which is a very dicey thing which happens because fatty is enlargement, atrophy is something which is collapsing. But then yes, you have atrophy and fatty. That is the classical thing which happens then, and we had to notice that. And then yes, I can say that yes, it was a AFLP. But then obviously that time I don't have anything else supportive. But then retrospective, we do think that yes, this is something which we could have saved or we could have managed. Because yes, the fatality or the mortality is very high when it comes to AFLP if not managed well. And the only solution is terminating the pregnancy one or getting a liver transplant by the time the patient is done with the entire pregnancy part too. So that is what happens. So,
Yes, actually, the literature says the mortality has decreased from 75% to less than 5. So I think that is
yeah,
pretty good. But I also was reading,
yeah,
Dr. Manish, that
yeah, yeah.
polydipsia is the presenting symptom. Is that right?
Yes, ma'am.
Is that
It is.
right?
Yes, yes.
Uh-huh. You
Polydipsia,
see that?
polyuria, like the case
Okay.
Dr. Ash was talking about, they present with frank, full-blown vernix encephalopathy. They come
Okay.
in delirium, and if you test their B12 and B6 levels, they are precariously low. Uh,
Mm-hmm.
I technically cannot explain why that happens, but yes, this is a known thing. And these patients also have all the signs of fulminant hepatic failure. If you look at the criteria for FHF, they fit everything. So these
Everything. Okay.
patients have to be on an accelerated transplant program, irrespective of whatever happens. I mean, obviously, you would want to deliver them because that takes away the major motive force for the decompensation. At the same time, post delivery also, to save the mother, a transplant is mandatory, absolutely mandatory.
Uh,
Okay.
so I guess that covers the four major parts of topic which I was thinking that we'll talk about. Lastly, just maybe we'll touch a bit on viral hepatitis because that is something we actually don't manage. Dr. Manish, viral hepatitis and pregnancy.
Yeah.
What do you have to suggest on that?
Okay.
Actually, hepatitis B you discussed, doctor, because we
Yes.
only see the hepatitis B.
Yeah, so
Yes.
that will
Okay.
this will cover hepatitis B
So let me
B.
and
start.
A.
Let me divide the hepatitis into two parts, and I'll also keep one part for drug-induced liver injury because that also is something which in pregnancy we are seeing quite frequently. So let me start with the fecal-oral hepatitis, which is Hep A and E. Like we discussed, these can lead to cholestasis and all the signs of hepatitis. Most of the times, these will be self-limiting. The treatment doesn't change for a pregnant female from, say, an average person. You would just want them to be well hydrated. You would want them to have less fatty diet and a more sugar-rich diet if they are not diabetic, and take rest and give them symptomatic treatment for any vomiting and nausea which they might suffer from, which could be part of the pregnancy or could be aggravated by the hepatitis itself. So that pretty much would be my recommendation for Hep A and E. Except that for Hep E, if it is the last trimester, I want to see these patients every 3 to 7 days because these are the patients who are very likely to decompensate, and I keep a very tight look out for any sign of decompensation in the last trimester with Hep E. So it is that last trimester with Hep E which is actually something which we consider as a
Dangerous.
semester presentation. Otherwise, Hep E is pretty much self-limiting and quite a mild disease early on in the pregnancy. Now, coming to Hep B and C, these are the enterally transmitted ones. So you can have two scenarios. You can have a patient who was a carrier for Hep B and became pregnant, So this is a patient who's considered what we term as an immune tolerant carrier, who is harboring the virus, may or may not be active. Is the patient active or not? Is the virus multiplying or not? We find out through what is known as the PCR test, which is the HBV DNA, which is a quantitative test. If the values are high, during pregnancy, we would want to put the patient on lamivudine, which is an antiviral. It is given in the dose of 100 milligrams once daily, carried through to term. And once the patient delivers, we definitely insist on the child being tested for hepatitis B, because there is a chance of vertical transmission there. If the child is positive, even the first 24 hours of birth, they need to be given immunoglobulins, H big as it is called, which in the dose of 0.06 milligram per kg body weight. The child is given that, and after a month of that, the child is also given active immunity through vaccination of hepatitis B. With this, we are able to prevent transmission from the mother to the child to the tune of 95 to 98%. Now, coming back to the mother who has delivered, lamivudine is a weak antiviral. So once the lady has delivered, we would want to shift them either to tenofovir, which is a more potent antiviral for Hep B, and occasionally we would put them on entecavir, which is also an equally potent antiviral. With these things, we can manage the patient very well. Please keep in mind that many a times the patient might become acute viral hepatitis B positive during pregnancy. Now, this is a different kettle of fish from the chronic condition which I discussed earlier. Acute hepatitis B follows the same course like any other hepatitis, but you test the patient after the index positive for hepatitis B. I treat the patient like a chronic Hep B, and if the patient has cleared the virus, which is what happens with 95% of the patients, we consider the patient as immune competent and cured of Hep B. So please keep in mind there are two scenarios. One is a chronic carrier becoming pregnant and carrying to term. So this is treated differently from, say, acute hepatitis B, where we do not use any antivirals. But yes, if after 6 months of the index infection, the patient continues to be positive for HBsAg, we consider that as a case of chronic hepatitis B and we would want to treat. When it comes to Hep C, most of the antivirals are teratogenic, and we do not give any pregnant female any treatment for Hep C during pregnancy. But the moment they have delivered, we would want to put them on oral antivirals. And the good news about Hep C antivirals is that these are all oral and they are pan-genotypic, because there are 6 types of Hep C viruses. You do not need to check for the genotype. You can give it. Now there are drugs which are pan-genotypic. Just get a HCV RNA quantitative tested, give these medicines for 3 to 6 months based on those reports, and you get up to 98% resolution of Hep C. Uh, if we play our cards right in our country and don't misuse the antivirals, probably after smallpox, Hep C might be the second viral disease to be eradicated, because these drugs are that good and that potent. So even for pregnant females, waiting for them to carry on to term without treating them with antivirals is not fraught with any risk. You just need to monitor them, and later, once they have delivered, they need to be put on these antivirals. And if the child is positive, even the child can be put on antivirals and will do well with very low risk of chronicity, less than 1 to 2% at the end of the treatment. So I hope I have answered your question in a roundabout
That
way.
was that was a
But
master class in hepatitis in pregnant for us.
I mean, any questions you have? Anything which I
I
have?
guess no. There's I don't think there's anything which you've missed out because you've covered it broad base, and even you've reached out to the important aspects. And I like the point where you put across that if we work around it well and if we are very vigilant enough and we try managing it, then I guess hepatitis C is something we can eradicate. That is something which is very important that we carry on from today's topic. I guess we have covered most of the important parts and we've touched on the important things. Dr. Madhu, you want to add something for before we end the talk for today?
No, no, it was a very enlightening session. And yes, I think we have come a long way in fighting the battle against hepatitis. And I'm sure next we have
And in
until
general,
next year. Yes, definitely.
And in general, we have covered a long way when it comes to managing liver disease in pregnancy.
Liver diseases, yes. A very
Absolutely.
vast
Yes.
topic in 1 hour is very difficult to cover.
Yeah. Yeah. So I guess we are done with the time. I thank you all, Dr.
Yeah,
Madhu and
thank you,
Dr. Manish.
doctors.
It was great learning and sharing all our experiences with all the doctors out there. Yes, it's a very vast topic. We have tried to just share our experiences from today and our past experiences so that we can. Main thing, I guess, the short thing which I can elaborate, and I guess I'll say it for all out there, considering the both other doctors, is that clinical scenario, evaluating the clinical scenario and getting a proper history is something which always become important rather than just relying on investigations. Yes, that will form a part, but then that's step two. So examine the patient as a whole, not just parts of it. Get a proper detailed history about all the issues that she is going through, and then ask for the necessary investigation, whichever is required, and be very specific that what you need to look onto it. And I guess once you start doing that, and the most important thing is nowadays being a medical legal era that we live in, it's always better to involve more doctors and have a multidisciplinary approach rather than just breaking one head and then trying to get into the crux of it. Because yes, there are something which I might know and something which I might not know. So as Dr. Manish is there, he's the one I have, like today itself, I have learned a lot with Dr. Manish being around with us, and Dr. Madhu with her experience. We have come across something that she has also seen in her practice. So I guess that is the moral of the story. If I may add to the end, that yes, evaluate better and keep an open mind to the things that you come across.
Yeah,
Yes.
thank you so much,
Thank
Uh,
Doctor. I think all of us have learned some new things from each other.
Yeah.
Gynec is something which scares the crap out of most gastroenterologists, let me tell you. Uh, and
Oh my.
liver might appear intimidating to you, but we are usually very, very apprehensive when we deal with the mothers, because it is an emotionally fraught time for the mother, and the families are obviously very anxious. And like you rightly said, we've come a long way, but still the liver and the pregnancy is an uneasy relationship yet. Many times we do find things going southward very rapidly. Like you rightly said, a good history taking, being clinically
Clinical.
tuned, and not being very investigation driven is the key. And I think most PGs who are listening in, or the practicing doctors, would do well to practice that, because investigations can sometimes also mislead you.
Honestly, yes,
do,
yes,
do
definitely.
listen to your gut feeling. As a gastroenterologist, I always say listen to your gut. It pays my bread and butter. I always believed in listening to my gut, and it rarely takes you wrong. Most of the times it will guide you in the right direction. So
Thank
thank
you.
you so much for having me. It was great talking to Dr. Madhu and you, Dr. Ash. I incidentally trained in Mumbai, so I completely empathize with your shea butter and cocoa butter. I was at,
Yes.
I did my DM and DNB from Sion Hospital, and Hinduja
Okay.
is where we would go to see the nice things in life. After that,
Yeah.
yeah.
Yes. Dr. Madhu, you would like to say something before we end?
No, no, it was a very nice experience talking to both your esteemed people. And it definitely, our government sector also is definitely giving a lot of chance. So maybe next year, as I said, we will also be a little bit on par of with you all. We have a very good gastroenterology department in our Usmania. And definitely, we are going to come up to your level next year.
I think,
Thank
madam,
you.
you are
We are
Thank
gaining
you
already
both for the
experience.
nice time.
you,
Thank you.
you guys are doing a much better job than us, because you're working in a resource constrained environment, and you're
Yes.
dealing with numbers which we can only dream about.
We
So
are getting the experiences
Yes.
from your studies that you have been conducting,
absolutely,
or we are
absolutely.
coming
Yeah.
across. So that is how it
Yeah, we all are doing a lot of studies now. Only we don't have resources, we don't have hands. So I suppose you both maybe remembered of your PG days where I'm still working.
Yes,
Yes.
definitely.
Uh, With that, I
Thank you
guess
both
I'll
doctors.
end the talk for today. Thank you everyone for coming out
Thank
here
you.
and being a part on the World Liver Day. And we are also happy and glad that we could share our experiences to all out there, that you also become better clinicians and don't have to face any troubles during managing liver disease in pregnancy. On behalf of team IGCP and Batul and everyone out there, and Dr. Madhu and Dr. Manish. I wish you a good day ahead. Thank you so much.
Thank you.
Bye bye.
Thank you. Thank you so much. Okay.